Hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode. Hello, everyone. Welcome back to the Feeding Pod. Brie and Olivia here today, and we are going to be talking about tube weaning. Today's episode is going to cover what we look for as a dietitian or an SLP, what are the readiness signs for tube weaning, how to control hunger and satiety cues while a child is on enteral feeds and during the weaning process, the different methods for weaning, and how it impacts the caregiver-child relationship. So, Olivia, why don't you give us a quick start on what it is that a dietitian looks for in terms of tube weaning?
So as a dietitian, first off, we want to make sure that they are medically stable. So for example, they've been released by speech therapy, everything's cleared for swallowing, they've got that feeding skill set, GI is looking good, respiratory, all that fun stuff. So some of it's the same as a speech therapist is going to be looking at. But not only are we looking at that, we also look at nutritional intake, including their macronutrients and their micronutrients, along with their anthropometrics. We are typically the ones that assist the family in the overall weaning plan, where they're coaches on, hey, we're going to take this much formula off today, and we're going to take this much formula off the next day. And then hopefully within the next 2 weeks, 3 weeks, sometimes kids can be weaned in a week. It just depends on the kid. Hopefully we're the ones that are there coaching you through it and guiding you through and making sure your kid's getting enough.
Yeah, and I think the dietitian plays a really great role in helping with like caregiver comfort, because a lot of times it's scary when you're thinking about tube weaning when your child's been dependent for so long. And so it's that reinforcement of, okay, they're getting adequate nutritional intake. This is what's going to go on while we're doing that.
Yeah, because you've got to think about it. That caregiver has been in charge of exactly how many calories that kid's been getting, exactly how much protein, how much calcium. And you've got some caregivers that come in saying, okay, I know my kid's getting this much calcium, but are they going to get that much calcium when we change to regular foods? Are they going to get enough calories? How do we know that they're getting enough calories? So we try to assist with that whole. Sometimes you just got to let things go. We're not going to be able to count calorie for calorie like you do with the formula. Mm-hmm. It's just a letting go process that we're helping them with.
Learning to trust your child to do it on their own, which is why tube weaning, it's so important to take this like interdisciplinary practice when you're working on it, because then you have everybody on the team monitoring the different parts.
Yeah, I think tube weaning is the one thing that definitely requires that multidisciplinary approach.
Absolutely. So from an SLP perspective, again, we're looking at some things that are overlapping. So medical status. And so in this realm, we're like, okay, is GI under control? How about like cardio system, like cardiac system, respiratory, neuro, like whatever it was that had the child getting that G tube to begin with and maybe preventing them from moving forward with oral feeds. And then we're also thinking about their feeding skill and their swallowing skill. So can they safely consume at least one texture? We're not worried about them eating anything and everything at this time, but if we're going to be weaning it, we need to know orally, are they capable to safely consume that new, like adequate nutritional intake?
Yep.
Okay, so going into the readiness signs for tube weaning, which we slightly touched on, but there's 5 really big ones that I think we both agree on. Is the medical status has been managed. So like, why do they have the tube feed? Why did they have it in the first place? And is
Resolved.
whatever that reason was, has that been resolved? Or is it to a point that it's managed so the child is capable of taking an oral feeds? And I think this is where we overlap a lot, because I'm looking at like medical status. Okay, are they capable of safely getting the oral intake? But then I have to look to the dietitian to be like, well, if we reduce something and this is what they're safely can consume, are we still going to?
We also have to make sure that they can take in at least one texture or type of nutrition. So even if that's just drinking the formula, switching from the formula going into the tube to the formula going orally, we're using those muscles, we're working everything that we need to be working. And then maybe from there, the speech therapist can get them to a different texture or to the next level up.
Exactly. Which is why having that safe swallow, the big point number 3, is so important. They need to have a safe swallow for at least one of those forms. And I feel like that happens a lot with children tube weaning, is sometimes it's, okay, we're doing some real foods, but the formula is also still needed to supplement at this time, but they need to be able to take that orally if we're going to be trying to wean the tube out.
Yeah.
And then the next part goes into your realm, is like tolerating a bolus feed schedule.
Yeah, because a lot of times when these kids are in the hospital, for some reason, we always start on continuous feeds. Continuous feeds can be anywhere from 10 mLs an hour up to 30 and 40 mLs an hour. It just depends on the child. It depends on the cycle that they get put on. And if you think about it, that's taking away their typical meal times, which then takes away their hunger and satiety. So we have to make sure that they can tolerate bolus feeds to ensure that they'll be able to tolerate a meal per se.
Mm-hmm. And just as a reminder to everyone, like bolus feeds is where you're really wanting to try to mimic what every meal of the day looks like. So doing 3 meals a day so that can their system handle that? Can their stomach handle like that, whichever amount of volume is appropriate for that child, so that when you switch it to doing oral feeds and foods, can they do it on that same schedule?
Yep.
And then the last one that I feel like is sometimes overlooked is the family ready, because it is very traumatic for not only for your child to get a G tube and go through that entire process, but then when you are going through the wean, that can be really scary.
It goes back to that control. The parents were in control. They knew how much their kid was getting, and now it's left up to that child to eat the meals. And is the family ready to let the child eat the meals? Or are they still okay, my kid has to get this much in a day, which can be difficult. And we'll go into it more, but that's definitely a psychosocial where I think more psychologists should be used in that realm. And I don't know how often here where we live, how often a psychologist is involved with tube weaning.
Yeah, unfortunately, it's not. Like, I know we'll talk to parents and try to suggest that maybe working with a counselor or something like that's important. And I think that's important. That's like I think
everyone needs one.
Mental health support, because it's so important, but especially these parents that are dealing with events that are really difficult. The other thing that I think is important to consider with like family readiness is like, what's the environment look like? Do they have a newborn baby and the mom is just not going to be able to at this exact time be able to put in what is necessary for this tube wean? I think that's something that we have to talk to the parent about as well, because as exciting as it is to be like, okay, we're going to work toward getting your child's tube taken out, the family's not ready, it's not going to be effective. And so we really have to have parent buy-in, but then also talk about those other psychosocial factors, like what's going on in the environment, what's going on in that caregiver-child relationship that might impact it not moving forward.
Yep. We actually have a patient. That's pretty much the reason why they have not been weaned from their tube. Just because mom's got too much going on. She can't focus on getting that child weaned from the tube because she's got 2 other kids that she's also focused on. Yeah. And one is a couple months old.
Yeah. And I get it. Like life happens, and you have to like respecting the family in that realm is just as important, because you could push as much as you want as a professional and nothing's going to happen if the parent isn't like full on ready to go. And that's okay. There's going to be a time that they're ready. And if it's not right now, okay, let's continue working on skills. Let's continue. There's so many other things we can do. I think sometimes we think like tube wean is the end all be all, but there's so many other things that we can do to improve their quality of life and improve their function without it being this.
Yep.
Okay. Moving on into that next part. So just real quick overview. So medical status, stable and has been managed. They're willing to take in at least one type of texture or type of nutrients, even drinking formula. They have a safe swallow. They can tolerate bolus feed schedule and that the family is ready. So before we go into like actual methods of weaning, Olivia, give us an overview of like, how can you help keep hunger and satiety cues while tube feeding? Because I know this is a topic that we both get
yes.
a little.
Yeah. And we actually, with Vanessa, whenever I did my podcast with her, we went into a study that talked about the baby-led tube feeding. So the infants in the NICU were leading their own tube feeding by showing those hunger cues, and then the tube feeding was being administered. But in reality, most kids come out of the hospital on their cyclic feeds. Typically, they try to get them transitioned over to bolus feeds, but it doesn't always happen. So the whole thought process behind keeping your hunger and satiety cues would be doing the bolus feeding. So if it's an infant, looking at, okay, what is a typical feeding schedule of an infant that's 1 month old or however old the infant is when they're being released from the hospital. Okay, if it's the 2 to 3 hour mark, we're going to give a certain amount of volume, which would be the typical amount of volume that that infant would take at those 2 to 3 hour marks. Some of them might be 3 to 4 hours, but that's the thought process behind it is, okay, we're giving the infant time to get that hunger, and then we're going to feed them. And then they should reach that satiety. Now, sometimes it works, sometimes it may not work. So that's another thing that we have to factor in. Are they actually going to get that hunger sensation, or are we going to lose it? That's one thing we notice that's difficult with tube feeding is a lot of these kids lose their hunger and satiety cues. So that seems to be the biggest issue that we have with tube weaning.
And that's where, I mean, for so long, their hunger and satiety cues have been completely suppressed.
Yep.
Because you're, as a professional and a caregiver, like you just want to make sure that the child's getting what they need. Like at that point, if a child is receiving tube feeds, like their medical status is what is most important. Like they have to grow, they have to get the nutrients that they need so that they're not just lethargic, dehydrated, a lot of those things. There's plenty of kids that I work with that they just hold on to that tube for medication and hydration. Yeah. And they eat everything else, but it's still
great, but
that little bit. Exactly. But and that goes where, okay, maybe full tube wean, we're not ready because we can't safely swallow liquids enough to be hydrated.
For example, as our kids get older, let's say this kid's in the 6-month realm and they just got a tube placed. Some things that you can do to help support that is before you administer the tube feeding, talk through hunger cues. Ask the child, are you hungry? Are you ready to eat? And as you're administering that tube feeding, have them suck on something like a passy. That way they're making that gut-brain connection and they're going to secrete those oral digestive enzymes that actually help with digestion.
And now instead of thinking that, because a child cognitively will make those connections of like, oh, this tube is what makes my belly feel better when I get hungry. But if you can give some form of oral input, even if it's like small tastes of the formula or little taste of a puree, or even just a pacifier that doesn't have anything on it. You're at least
to get that.
Yes, it's that connection of, oh no, something had to happen at my mouth in order to feel that. And I really think from the start, that is something that should be implemented.
It should.
Because even our kids that don't have a safe swallow, okay, they can do oral play, oral exploration. They can start with the pacifier. They can do pretend with the spoon. Maybe it's just a cold spoon. So we're just getting some form of stimulation.
Yep. And once they've been approved and safely swallowed, like Bree said, you can start offering just a smidge amount of formula that way as you're giving it down the tube. You can, if they're ready for purees, you can offer a spoon of purees or something for them.
And I think something else, and this kind of is something that will happen sometimes when you're first starting to tube wean, is like offering them whatever it is first orally. And then finishing with the tube, because we get it. Like the kiddos, maybe they don't have the skill or the endurance to be able to finish an entire feed, especially like the littles, like infants, bottle feeding, like they might just, it's just too exhausting. But if they can do some of it, when we think about neuroplasticity and those sorts of things, like use it or lose it, use it and improve it. So we really need to be trying to mimic what the ultimate outcome is going to be.
Yeah. And a lot of times I even like to think back to, okay, whenever you're weaning a perfectly healthy infant from breast or bottle onto solid foods, it takes time. So the tube weaning process is going to take time. You don't just take the bottle or breast away and say, all right, here's all your food. You're going to eat all of this now. You got to think these kids, even if they're 2 and 3 years old, they're learning new skills. This is all new to them. So it's going to take time. They're going to still require some form of supplement, whether that supplement is still through the tube or it's a supplement that they're going to drink.
That's such a great point, because when we do introduce kiddos to foods for the first time at 6 months, we don't take away anything until another 6 months plus.
Yeah.
And ideally, you're reading their cues on when they're ready for the rest to decrease. But that's a great point. It's the same thing for these kids. Even though they might be older, they're going through those same stages just a little bit.
It's just at a later point in life.
Yeah, I love that. And then something else to consider is that you might be doing bolus during the day. And if because you're working on those hunger cues, but then getting those nocturnal continuous feeds can still provide that like reassurance that they're getting what they need.
Yes. And I like to say if we are providing nocturnal feeds, then we need to stop that nocturnal feed 2 hours before you're going to provide a meal. So that needs to be 2 hours before you're going to offer breakfast. That needs to be stopped. And if that breakfast is a bolus, it needs to be stopped 2 hours before to allow that hunger cue to come in. It doesn't need to be, okay, we did our whole nocturnal. Let's turn it off. Now it's time for your bolus. That kind of then it's defeating the purpose
of giving them their appetite.
Yep.
Okay. Yeah, that's awesome. And I think that's something important for all of us as clinicians to consider is, okay, maybe we're not fully ready for a tube wean, but what can we do in the meantime to just promote pre-feeding skills, appetite increase, and getting the child like on a schedule that will be ready for it when they are.
Yep.
Okay, so diving into the different methods of weaning. So overall, there's many different ways that this can be done. So it can be in person. We've seen virtual or like net coaching, which is a lot of family involvement, which is wonderful. There can be a combination.
That's actually becoming a big thing, the net coaching.
Yeah, which I think is great, because if a child really has been,
they're safe to swallow, they've got their skill set,
then you can have net coaching done just to guide it while they're still getting whatever services that they need where they're at. So especially for people that are in more rural areas or want to do one of these more intensive programs, that is like wonderful.
Yep.
And then there can be outpatient, inpatient, and all of these can be at varying intensities. I've seen kids weaned as quick as a few weeks up to a year. And so much of that will depend on what's going on with the family, but then also the child's status and how much time they might need to completely if we're doing child-led, how much time do they need to be able to get there?
Yeah. And you also have to think, okay, how long has this child had the tube? If they've had the tube for a long time, it's going to take a long time to wean them. If they've only had it for a short amount of time, it's probably not going to take as long to wean. So that needs to be another factor into that too.
And also, why did they have it? Because depending on what is being managed, some things it might be like a trial and error of, all right, can we work them toward a more structured schedule? And then if their body isn't able to handle that, okay, we're not fully ready for a wean. And so I think there's definitely things you consider that are almost like pre-wean, like you're getting ready for it, but you have to test those out before the child, family, everyone's like, okay, yes, we're ready to go. You have to, and that's why we need the team approach.
Yep. And you have to think about the changes that the GI tract is going through during all of that, because you're giving them formula. Formula is pretty much already broken down to the form that it's easily digestible. Now, if we're going to be adding in real foods, how is the child doing with their GI tract? How's their GI tract handling it? Are they getting a lot of gas from it? How are their bowels doing with it? There's a lot of things that come into play with this tube weaning that we just don't always think of.
Yeah, which, is why it's so important to work together, because if something like that comes up, okay, well, is that something we can manage so we can move forward? Or do we need to hold on and the child's body needs to, reset and adjust and get where they need to be?
Yep.
Okay, so Olivia, why don't you go ahead and explain this like first weaning method, the hunger inducing weaning method. We've also heard it called child-led or a gradual wean, and what that kind of entails.
So I think this is, I hate to say that one method is better than the other, but this method, it's kind of led by the child. So honestly, I think a child-led method is probably going to be the best bet for your child.
This is definitely our favorite.
That's my thought process whenever it comes to all of these different methods. But everybody's different and every child is different. So your child might do better at a different version. But basically, the hunger-inducing method is you're going to wait for those hunger cues to come. So in order to get those hunger cues to come, we've got to stimulate the appetite. So your appetite stimulated by energy intake. So the less we give them, then hopefully the more they'll start to feel hungry. So what you can do there's a couple of different ways you can go about the hunger inducing method, but a lot of times it's decreasing the amount of tube feeding that you're giving. That way, okay, they're not getting as many calories. Maybe we should start getting this hunger sensation back. Mm-hmm. So a healthy child usually gets that hunger sensation within a few hours. So let's take, for example, like a 1.5, 2-year-old. For example, most of the time they eat a breakfast. Then a couple hours later, they have a snack. Then a couple hours later, they have lunch. And then a couple hours later, they have snack. And then they have dinner. Some of them require another snack in there. So every few hours, we're eating. They're getting that hunger. They're ready to eat. Now, your tube-fed patient might not always get that because we're always giving something. We don't always give that time. So maybe if you decrease the amount of your tube feeding, we're thinking, okay, maybe we're going to get that hunger sensation. From there, a lot of times it's offering that food first, seeing how much they eat, and then offering the tube feeding after. Now, if they eat a lot, you don't even need to give the tube feeding. But if they only eat a couple bites, okay, great. They took a couple bites, and then you administer your tube feeding.
Even with that, with like trying to stimulate the appetite for these kiddos that have had their appetite suppressed for so long, or like they might feel a little bit of hunger, but then they're getting a full feed every single time. It can take them a week or two to even like regularly feel those hunger cues and recognize that's what that is.
Yep. Hunger, it's a complex interaction of sensory input. You have the limbic and you have the cortical modulators along with the visceral feedback and the hormonal effects. So we have to get all of that going in order to get that hunger. And if we're constantly pumping it in even before they get that hunger sensation, we don't know if they're getting hungry. They can't tell us if they've never felt it before. Let's say your child started receiving tube feeding at 6 months. They may not know what that hunger sensation is. So you're going to have to really take things away for them to be able to have that hunger. Mm-hmm. So if we stimulate hunger, then we can drive them to start eating. So for a speech therapist side of things, if we can, as dietitians, can make this child hungry, then they're going to be more willing to participate when they go into speech therapy.
Yep.
So that's another thought process on that.
Mm-hmm. Yeah. And with this method, it's a little bit slower because we are following the child's lead entirely. So This isn't one of those methods where you cut their food by 50% or more and then just follow their lead from there. This is like very slow reduction to try to get them to do more orally before they receive the rest of their feed.
Yep.
I've also seen with this method where you're reducing during the day, but based on what they do during the day, then they're getting overnight to make up for it, just to make sure we don't want them getting lethargic. We don't want them to be dehydrated. We don't want any of those to occur. So as we're implementing more and more orally during the day, that might be something that occurs, even if they weren't getting continuous overnight before, but they were getting so much during the day.
Yep.
If by reducing it, we might need to supplement at night.
Yep. There's always, the dietitian's always in the background making sure, okay, if this kid only ate 3 bites and we only gave half the formula, okay, we've got to make it up somewhere. Where are we going to make it up? So we definitely make sure that we're either giving it at night or fitting it in somewhere else. There's one model, I think it's called the Graz model.
Notube.com's their website.
Yeah, it is. Yep.
Okay.
So basically the thought process behind this is you're inducing the hunger, as I said, by gradually reducing the amount of tube feeding given. And that's going to strengthen the child's autonomy. This is the same model used in pretty much all net coaching realms. So yeah, the no tube med, that's what they're using.
Yeah. And we both agree that this method's great because you're reading the child's cues, you're promoting that autonomy within them. So it's intrinsic motivation to want to feed, not extrinsic.
Yep.
And then it's just like, it's a less aggressive approach. And I think that a lot of times this is helpful with a kiddo who maybe they've been like, especially when they've been on the tube for a while, the family's ready to move forward, but they're, hesitant because they want to make sure that they're still getting everything that they need. And so this approach allows for it to not be so aggressive because you're taking small steps, reading the child's lead, and the whole team is monitoring the child's well-being at the same time. So all of those elements that were involved
a lot slower. This is, again, your child's going to be inpatient for 2 to 3 weeks.
A lot more.
Finally, roughly 80% of the calories are going to be taken away from that tube feeding orally. And then that tube feeding is just going to be stopped completely. So by then, they're just hoping that your child's going to be meeting their calorie needs by the end of this 2 to 3 week program. It is cut drastically, very quickly, but then again, you've got a lot of support following you.
And that's why with a lot of these programs, it's super essential that the child has been released from like a skill standpoint, a swallow standpoint, a medical standpoint. Yes. Everything else has been checked off.
Yeah.
But then while they're in the program, they're still going to be followed by everyone because as we mentioned with the other method, like this is going to change gut health very fast. So the child's digestive system is going to take a big change.
Yep. And sometimes that can cause some other aversions as well. And that's one of the things that scares me away from this method is, okay, so if I'm decreasing that by 50% on the first day and I'm dumping all this oral food, my stomach's probably not going to feel great. And then if my stomach's not feeling great, I'm not going to be motivated to eat. That's just my thought process on it. It's not to say that it doesn't work. Obviously it does because it's a program and people use it. But from my standpoint, I want my kid to feel good as they're going through all this.
Which is why it's a less responsive approach. Yes. So like, if there's a kiddo who is still getting maybe they've gone through the process of reducing some of their G-tube feeds. They only have a little bit left, but they're really just having trouble mixing these last couple feeds and they're holding on to it and everything else is going really well. And you just want someone to like very intensely go through it, but your child's being watched from a medical standpoint. This could be
great.
Yeah. So there is benefits and there are children obviously that go through it.
Yep.
But from our standpoint of an approach that's very responsive to the child, responsive to the family, and gonna generate, in my opinion, this is just my opinion, not like research based, but just more autonomy in the child to where they have intrinsic motivation to eat, then using the other method is very helpful. And I think the other method is also a lot more realistic for families who can't just pick up and 2 to 3 weeks inpatient somewhere.
Yep. That's a lot.
Mm-hmm. Yeah. And when it's basically just you go from first day cutting 50% to within a week or two going
cutting 80
and then to nothing. It's really fast. So, and then there's which this is a little bit like that, is like the intensive feeding programs. So this is really just a small number of children would benefit from this, but where they have extreme oral aversions, like not willing to take anything by mouth. And from a medical standpoint, they've been released. From a skill standpoint, they've been released, but they're super aversive to oral feeds. This might be where an intensive feeding program is helpful because you're going to be working on decreasing that aspect of what's going on with the child. I don't love these programs because they're very behavioral based. Take a bite, get a reward, take a bite, get a reward. So it's very extrinsic in nature. Like you're trying to get the child to eat based on what's going on in the environment, not how they actually feel.
Which I think this is why it's only good for a certain number of people.
Very, very small number. There's a study that I absolutely love. One thing I want to mention with the intensive feeding programs is there's this study that was done, and we'll list it in our references, that states that over 97% of participants in a behavioral feeding program had underlying medical conditions. And so like that alone, like that statistic, that's huge. And that tells you like how small it is where a child, like everything medical has been ruled out and it's just behaviors that are going on. Because we talk about that all the time. Like behaviors are responses. They're not behaviors. Behavior has such a negative connotation. And in these situations, programs like that are based on behavioral things, like it is few and far between that is actually beneficial for a child.
Yep.
Mm-hmm.
Which is why we say only a small number of children need this intensive feeding program.
Yes. But yeah, so just all in all, there's the hunger-induced or child-led or gradual wean. There's the clinical hunger provocation, which is physician or therapist led. And then there's the intensive feeding programs. Those are the main three ways. And Olivia, kind of when a child's going through a tube wean, we always hear from parents like, what about weight? Because that's a big fear about what could happen.
So weight loss is going to happen. Once again, let's go back to whenever your infant's born, they lose weight right away. B, when your infant transitions from breast and bottle over to oral, they lose weight. It's going to happen. Typically is 10%. That's how much you're going to expect to lose. Some, of course, are going to lose more. Some are going to lose less. Some may not lose any at all. If they do lose more than 10%, then that is something to take into a factor and say, okay, maybe we do need to bump back up the tube feeding, or maybe we need to offer some more nocturnal something because we don't want them losing more than 10%. It's going to take time. It's going to take time to gain appetite back. We're not going to expect that appetite to come back overnight. We didn't take away the appetite overnight. This is what I also like to tell people that are talking about weight loss and weight gain. You didn't lose the weight overnight, so you're not going to gain it back overnight. Your appetite is it's going to take time. Mm-hmm. Weight's going to take time. So just expect that to happen and you roll with it. And I know it can be pretty difficult because this whole time you've been thinking, okay, I've got to give this much tube feeding to make sure they're gaining enough weight. And now we're taking that away.
The reason they got the tube, like they're not gaining weight, they're not growing. And so that's a really hard part to let go as a caregiver. And I think sometimes as a physician, because you're like, ultimately that's why we did it. And so that part can be hard too.
Yeah. And now we're about to take it away and we're expecting you to lose weight. So it's just, we've got to factor it in. We've got to know that it's going to happen and we don't need to freak out whenever we see, oh my gosh, they've lost 3 pounds. It's just something that we got to take in.
It's going to come back, because if we don't think it's going to come back, we're going to reassess the wean. We see signs that the child is making progress. Let's continue. The weight loss is okay. We're going to keep going. Yep. If we see there's a weight loss and the child is not showing signs that things are going well and improving, okay, we're going to reassess it, which is why that team approach is so important.
Yep.
So 100%. Something else that I always mention this to caregivers, and it's one of the reasons that a GI is so important to have on the team, is in relation to tube weaning. I would say most of the GIs I work with, if we're working on weaning a child from a tube, and let's say we've weaned them and it's November and they have had 1 week where they haven't had to use their tube, and that's great. They're not going to immediately remove it. Most of them say like around, they want to see 3 months where they haven't had to eat, especially depending on how long the child's been on it. If the child's been on it shorter term, and maybe they've had their tube for 6 months, if they're off it for a month and they're medically stable and doing well, then they might remove it. But it's so much easier for them to remove the tube than to put one back in. Yep. So they're going to wait. And another thing that GIs and just physicians in general will consider is like, is it flu season? Is it respiratory season? Is the child going to get sick? And so they're not going to eat and they're going to really need that for their hydration.
It's a good insurance policy is what I like to call
it. Yes. And so that's why even when you're doing these weans, okay, we weaned them, they're not using their tube, they're doing really well. It's been a week or two and we're like, great, continue it. They're not going to get it removed right away. So you have that, like you said, the insurance policy of like, all right, if we have to refer back to it for whatever reason, we can.
Yep.
And I think that's something that when I tell caregivers and stuff that as well, where I'm like, if your child gets sick and they're going to need something, we have it. Like, it's okay. We still have that right now. So is there anything else you have from those? Any other points to make?
I think that's it right now.
Okay. So going into the last part that we want to touch on is the caregiver impact and just the positive and negative associations with tube feeding. It's a complex decision to get the tube, and it's also a complex decision to wean from the tube.
Yeah. Those are two very big decisions that caregivers are making. It's almost, okay, my kid's not gaining weight. What have I done wrong? Why am I causing my child to have to get this tube? And then to wean it, it's, oh, I know that my child was getting everything that they needed. They were gaining weight. Now, if I'm starting to take this away, I don't know that they're going to get everything they need. I don't know that they're going to gain weight. Right. This whole thing's a big process for caregivers that sometimes we don't always think about.
Yeah. And there's one study by Wilkin from 2012 where it's like the impact of child tube feeding on maternal emotional state and identity. And I love that study because as a mother, and really as a father, but mostly as a mother, you have this internal instinct to feed your child.
Yep.
So when initially your child got the tube, you completely lost that. Like you feel
like a failure.
Yeah, and you lost that connection. Oh, I don't get to feed my child. That's the one thing I was supposed to be able to do. And that can be really hard. And then, okay, they overcome that and they're doing really well and their child is growing and you're like, okay, we're going to talk about getting rid of it. And I just got
the hang of it.
Yeah, I just got into the position where I was good. And
now you're wanting to take it away.
Yes, exactly. And so just like that, the stress and the trauma that can cause from just that standpoint and just like touching on their identity as a parent.
Yep. Because as a parent, that's what you do. You take care of your child, you feed your child, you make their meals, you sit down and you enjoy a meal together once they're old enough to eat at the table with you. And you're still hopefully putting them at the table as you're giving them their tube feed, but it's just completely different.
Yeah. Mm-hmm. And
it's a lot to learn too.
Yeah. And especially a lot of the families, I know a lot of the families we work with, like they didn't get support from the beginning.
No.
So they didn't know, oh, I was supposed to still bring them to the table and try to establish that. All of those things that build on that caregiver-child relationship and connection that from the start, and sometimes it's a very traumatic event that led to the child getting the tube.
Yep.
And so that just like instant change in their life is so hard on that relationship. And we know how important that relationship is. That is an area where there is extensive research. There might not be a lot of research on PFDs, but there is so much research on caregiver-child relationship and interactions and connection and how important that is for development.
Yep.
So in this situation, that's where we talked about using psychologists and counselors. It really should happen more.
Yeah. And they're not utilized for this. I know in our area, now other areas might be different and they might get utilized, but from Brie and I, a lot of these parents come to us, they haven't even been told how much they're supposed to be giving their kid in a day. They haven't been told what a typical schedule should be. They have been told no, they've been told nothing, basically. They know how the equipment's supposed to work.
Used Dr. Google.
Yeah, a lot of them.
How to feed. And they're like, but my child's throwing up. And then we're like, okay, how about you talk to Olivia? And we find out, well, they're being overfed.
Yeah. You're feeding them like maybe 100 mLs too much. That might be why they're vomiting. But yeah, there's not very much support with kids and tube feeding around in Greenville, South Carolina for some reason. I'm not sure what's going on here, but
yeah,
there's just not very much support. There's a lot of moms just figuring this out on their own. And I will give it to them. Some of these moms come in with these awesome schedules and they're giving their kids the correct amount of calories because they've Googled how to calculate it and how much they should be getting. And I've been pretty impressed.
Yeah. And like some of these moms, they're like powerhouse super mamas. I'm so impressed with what they come in because they haven't been given any support or resources.
No.
And so we're the first people to be like, wait, what do you mean you don't have a GI? What do you mean you haven't worked with a dietitian? What do you mean you haven't had a feeding therapist to work on improving the skill?
Yep.
But it just, for some reason, seems to not be happening.
No.
And unfortunately, okay, they're going on Google, they're putting in their child's age, they're doing the equation, but they're not taking into consideration that their child has a genetic syndrome
disorder, and they're
that
way on the bottom end of a typical 2-year-old. They're technically the size of a 1-year-old, but you're giving them as many calories as a 2-year-old needs, but they don't need that. Yeah, they're also not as active.
They haven't been told otherwise. Yeah, exactly. Yeah. Or the kids that have, if you have a child who has like a spinal cord injury or cerebral palsy, where you want them to be on the smaller end so that motorically they don't have to go through as much resistance.
Yeah.
That they can build their skills that way. But if a parent's not given support from the beginning, and just to add to the trauma and the stress of the situation, then they're like, okay, good luck. Here you go. Just pump it through there. It's literally
good luck.
Mind blowing. I guess all of that to say, when you get these children, even before you're at the wean status, which I know is majority of what this episode was on, you need to advocate for them to get that team. Because if they don't have a care team, you're never going to get to a wean process.
Yeah. The whole care team needs to be together, coming up with these plans and talking with one another and discussing it. Because if they're not, then you've got one person saying this, you've got another person saying that, and no one's communicating with each other. Yeah. And the poor parent over here has no clue what they're actually supposed to be doing.
Yeah. And like, I wouldn't have known things like the GI is still going to wait 3 months, or they're going to make sure that it's not flu and respiratory season, unless I had talked to them about, hey, this is what I'm thinking about doing. What is it that you look for on your end to say a child can successfully wean? Because then I know better how to educate the families of what we're looking for. I know that like I have a safety net of, okay, we're not just, it's not going to get removed in a week. If I say, okay, we're good, that helps. It gives me insurance too of, okay, but it's still a process.
Yep.
So yeah, that's a long-winded response of why we need counselors.
Yeah. Yes and no. I think everyone in general, needs a counselor, because we all have things that 100%. We need help with, but especially with these caregivers, because they have so much on their plate, they need a little extra.
They do.
They're going to have a lot of anxiety over feeding. Even if it's feeding via the tube or feeding orally, they're going to be very anxious over it all. That's the biggest thing I see is the calories. They get so focused on the calories and the unknown of their kids not getting enough calories. That's the biggest struggle I have with a lot of these caregivers.
Mm-hmm. So they're afraid because for so long their child wasn't growing and wasn't developing, and they finally have something that is helping that happen. And I think feeding off of that too, like it's so important from the standpoint of a caregiver has to take, not to be like harsh, but has to take responsibility and control of what's going on in their mind, because the child feeds off of it. Yep. So if the parent is super anxious at meal times, the kid knows. They're very aware. They know that you're watching every step and you're making sure that this is happening. I mean, their kids are very smart and they feed off of that. Yep. I think that's just another point as to why a caregiver should seek that counseling and seek that mental health support in order to just better the relationship with their child as well. Well, thank y'all for joining us on this Tube Wean episode, and we look forward to talking to you all next time.
Yep. Hope you enjoyed it.
Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow Bree, me, on Instagram at Pediatric Feeding SLP, or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.